presentation is from a different area of cardiovascular treatment and prevention, namely it is a study on sleep apnea and cardiovascular endpoints. Professor Doug McEvoy from the Adelaide Institute for Sleep Health, Flinders University, Australia, is giving the presentation.
Thank you very much. It's a pleasure for me to present the results of this study, which was conducted over 7 years in 7 different countries. These are my disclosures, and they indicate the main funding for the study. Why did we do this study? First of all, obstructive sleep apnea is known to affect in the order of 40 to 60% of patients with cardiovascular disease. Secondly, obstructive sleep apnea is associated with elevated blood pressure, insulin resistance and endothelial dysfunction, which are all markers of cardiovascular risk, and longitudinal cohort studies have demonstrated that obstructive sleep apnea appears to be an independent risk factor for both cardiovascular morbidity and mortality. And both the risk markers and the morbidity and mortality in observational studies or short-term randomised studies have indicated some benefit both in terms of the cardiovascular risk markers and potentially also the morbidity and mortality. However, there is lacking presently randomised evidence focusing on hard clinical endpoints as to the benefit of obstructive sleep apnea treatment for cardiovascular disease prevention. So the study aim was to determine if CPAP treatment of moderate to severe obstructive sleep apnea in patients with cardiovascular disease would reduce the incidence of future cardiovascular events. CPAP is continuous positive airway pressure, and it is the standard treatment for obstructive sleep apnea. The study was designed as a multinational, open-labelled, randomised controlled trial in which participants were randomised to CPAP treatment for obstructive sleep apnea and the continuation of their usual guideline cardiovascular preventative treatment versus their usual cardiovascular care alone. The primary endpoint was a composite of cardiovascular death, myocardial infarction, stroke, hospitalisation for transient ischemic attack, unstable angina or heart failure. We studied 2,700 patients from 7 countries in 89 centres, and they were followed for an average of 3.7 years. Who did we study? The patients were aged between 45 and 75. They had to have established coronary or cerebrovascular disease, and therefore they were at high risk for future events. And we demonstrated by a simple overnight sleep study that they had moderate to severe obstructive sleep apnea. And we also required that in a short run-in phase of 1 week that they were able to use a CPAP mask for at least 3 hours a night. We excluded patients who had very severe sleepiness, and we judged them to be a potential risk for a fall asleep accident, and also patients who had very severe oxygen deprivation by the overnight sleep study. Patients with advanced heart failure, grades 3 and 4 of the New York Heart Association categorisation were also excluded clinically, and we excluded people who had central sleep apnea by measurement on the apnea link device. People who had had prior use of CPAP were also excluded. What did we find? There was no effect of CPAP treatment on the primary or, as it turned out, secondary cardiovascular endpoints. On a per protocol analysis in which we matched 560 patients who were able to use the CPAP for more than 4 hours per night consistently over the follow-up period, we found that there was a strong trend toward a reduction in cerebrovascular events in patients who fitted that category. CPAP, in contrast to the neutral results with respect to cardiovascular endpoints, significantly improved patient well-being. There was less snoring, less daytime sleepiness. There was about a 20 to 30% decrease in symptoms of depression, and there was overall improved quality of life, and furthermore, fewer work days were lost due to ill health. The study is being published today in the New England Journal of Medicine. For those that you are interested, you can obtain further information regarding the study findings and the methodology at the New England Journal of Medicine website, but I'd be very happy to answer questions at this point.
Thank you very much. There are many questions from the audience. Please make a start on the right.
Hi, Melissa Walton, Shirley from theheart.org. So do you have any idea about the average CHA2DS2-VASc score for the patients that were studied? Because I noticed the entry age was age 45, and if a large majority were male in their 40s or 50s, it might skew your TIA data.
Yes, I can't help you there. We do not have that information. It is true that the average age was 61 of the patients, and about 80% of the patients were male, as you say. And we expected that to be the case because of the predominance of obstructive sleep apnea in the male population. So I can't answer you on the CHAD score, unfortunately.
Thank you.
There's another one.
Jenny Budding, Medical Facts. You included and studied patients who were able to use the mask for 3 hours or more, the CPAP mask. How relevant is that for your conclusions?
Yes, you might say that is moves away from the ecological significance of the findings. However, it is common practice in sleep medicine for people to have a trial of the CPAP therapy. It's actually quite a difficult therapy for people to use, so it's often very common for them to rent or to borrow a machine or be loaned a machine to try it out first. And so this was a way of improving the efficiency of this study, but also it fits with clinical practice. So it was to demonstrate whether there was general acceptance of the therapy by the patients. And in fact, only 10% of the patients who went into the sham run-in phase were excluded on the basis of inadequate treatment or adherence to the treatment.
There's another question.
Simone Reisdorf, Midscape, Germany. The effect of CPAP seems to be dependent on the duration of its use per night, more or less hours per night, and maybe the time point of its use at the beginning of the night or maybe later on. Do you have any recommendations for that? And do you have any idea how to motivate patients to use it more than 4 or 5 hours maybe?
Yeah. Yes, it's a big challenge in the field, I think, to have people use this treatment throughout the night. That's the biggest challenge for the field. And you are right that there is some evidence that when you use it across the night may be important. There are some epidemiologic studies demonstrating that people who appear to use it only at the first half of the night who may not get the benefit, particularly in the latter part of the night when rapid eye movement sleep is known to produce much more severe sleep apnea, they may not have the benefit because of that. So there is some relationship between the timing of the treatment as well as the extent of the treatment in relation to hypertension risk, for example.
One more question, please.
Crystal Fenn with MedPage Today. How common is the apnea link device used in the United States setting, or is polysomnography more likely how people are going to be getting diagnosed, and would that impact the findings for application in the U.S.?
We do not believe so. There is a worldwide trend towards the simplification of the diagnosis of sleep apnea, moving away from the rather complicated and expensive polysomnography to simpler methods. Now, the apnea link study is one of the simplest, and its advantage was we were able to standardise the measurement across multiple centres and multiple health systems. And we did some validation studies prior to commencing the main trial, showing that it's a very effective way, an accurate way of identifying moderate to severe obstructive sleep apnea.
Perhaps one final question from my perspective as a cardiologist. In the past, we have always seen obstructive sleep apnea as a risk factor for hypertension and developing heart disease and stroke. So now you say that reducing obstructive sleep apnea by effective treatment does not change the endpoints. Does this mean that it's more from a prognostic perspective, an innocent bystander of the same shared risk profile, namely obesity, smoking, and others, alcohol, for example, that have the same effect on disease progression, both in regard to OSAS and heart disease?
That is a distinct possibility. For example, one possibility is that the observational studies have overestimated the risk because of difficulty controlling for confounders you don't know about, and for confounders such as visceral obesity, which was not measured accurately in some of the studies. So that is definitely a possibility. However, the strength of the association in the epidemiologic studies is substantial, and it is still possible, I believe, that we have not hit the target in terms of the amount of treatment necessary to modify the risk associated with obstructive sleep apnea.
Okay. Thank you. I think that was a nice conclusion.